Thank you as well for, in a way, introducing the next panel, indeed, because the next panel will be dedicated a bit more about independence issues. I would suggest that we take only very brief clarification questions, if there are. I'm afraid, but that's the rule of the game today. We don't have time for much debating before the end of the day. Yes, sir.
Good morning, everyone. Thank you very much for the presentations. I'm Yanis Natsis on behalf of the Transatlantic Consumer Dialogue. I would like just to follow up on something that Brendan Burns said at the very end of his presentation. He said that this discussion is about the current randomized clinical trials model of doing clinical trials, and that we're moving towards something else. And it's true, there are pharma-driven initiatives taking place at the EMA with the Pathfinder scheme, with the adaptive pathways, and we're seeing that there is a paradigm shift. So my question, I think, to all of the members of the panel, in particular to the gentleman representing the EMA, is this debate going to be made redundant in a few years, since we're moving towards personalized medicines, and since we have this pharma-dominated approaches to adaptive pathways and to the Pathfinder scheme? Thank you very much.
Yes, Ansela Santos from Health Action International. I have just some remarks regarding the EMA's policy. One of our main concerns is that there are going to be two versions of the clinical study reports, one for marketing authorization and one for publication. Regarding commercially confidential information, we think that it's really important that at least some parts of the justification table are made public, so at least there can be an independent assessment about the extent of the reductions and also the EMA's rationale for allowing some of those reductions. And regarding anonymization, it seems that companies have been proposing a method called Transcelerate approach, which apparently is very aggressive and would mean that the data would lose some clinical utility. So we really think that the EMA should be more prescriptive and forbid the use of these methods, and we really call upon you to include in that working group on data protection that you plan to set up independent experts on data protection and researchers, because what we see is also that companies are very much using the question of data protection to justify major reductions, and this is something that we are very concerned with. Thanks.
Thank you.
This is Jamie Page from the Cancer Prevention Society. First of all, to say I think this thing of publishing negative data is an excellent move, and I think that's fantastic. My knowledge, in the 80s and 90s, pharmaceutical companies had the formal clinical trials for registration, which were very well documented with all the apparatus in place for collecting those information and submitting to health authorities. In those days, I don't know if it's still the case now, but there were a lot of what were called at the time marketing studies, where small grants were made to doctors to pursue their individual interests. And even within the industry, there was a lack of good understanding of or collection of information about these marketing studies where grants were being made. So my question is, are those types of studies still going on? And if they are, is the information of those sort of what I would call almost pet interests of the doctors in question, are those information also being collated when the results are negative?
Last question here.
Thank you. Martin Dermine from Pesticide Action Network Europe. I first had a question to Mr. O'Regan. Is the Ombudsman Office active in trying to harmonize or have some coherence in the different EU policies on data transparency, the EFSA, the ECHA, and the EMA policies? And a question to Mr. Wattion. Do clinical research companies who do not direct apply to EMA, apply a new medicine, do these companies also have to report clinical trial data, or do only the applicants report for these data? Thank you.
To answer very quickly your question, the Ombudsman has had and has cases concerning access to documents with all of the three agencies that you mentioned, along with a number of others, and also the main institutions. Clearly, we learn from the various cases and try to use that knowledge to convince the other agencies to move forward as regards the issue of transparency. I mentioned 2 cases concerning conflicts of interest from the Commission and EFSA is just an example of, let's say, the cross-fertilization in terms of principles and ideas, information relating to this issue to move it forward. We are also, outside of the issue of dealing with complaints and own initiative inquiries, the Umira case is an own initiative inquiry of the Ombudsman. We also are actively engaging in dialogue with the agencies. Noel Wattian mentioned that we are in October, I think it's 19th of October, meeting with Emma to further discuss these issues. So yes, we are actively pursuing this issue with all of the agencies you've mentioned.
I'll try to be very quick. So in terms of the first question with the initiatives like Pathfinder, etc., and interaction with pharmaceutical industry, if I understood your question correctly, is there going to be a change in our attitude towards transparency, even despite? No. Why should there be? I mean, like I said, we have this transparency journey is ongoing, and I don't see why this should be stopped or if we should have a change to it. Comments about the anonymization. Also trying to come back to what other speakers at this panel said, it is not so straightforward, unfortunately. It is not, even if data are being anonymized at source, the way that companies complete their dossiers, you will have a lot of data where people can be identified through narratives, through line listings which are included in the body of the text. And that is what we have to look into. Even if we say that individual patient data would be a secondary step for the implementation, believe me, it's not only about small populations such as pediatrics, such as orphan diseases. It is a much more complicated issue that we have to deal with. We have to strike that balance, and important will be the 19th of October, where we will further discuss with both the Ombudsman and the EDPS. Anyway, the opinion of the EDPS we have to take into account. So we cannot say thank you very much, that is it. It's something that we have to seriously consider. The justification table, it's a very detailed thing. Anybody, so for people to understand what we are doing, companies, when they will be redacting CCI, have to justify. We will use a so-called justification table where we said that will not be made public, because at the end, where do we stop? Of course, you can ask access to documents for the justification table. But then please bear in mind, we have already doubled the number of access to documents requests this year with the same workforce. If we continue like that, and access to documents is a core issue, such as all the others, we will not be able to meet the deadlines in order to reply. I mean, we have to bear in mind that there is going to be a resource issue. I know that we are very much wanted in terms of providing access to data. We'll try to do whatever we can do. For the studies that have to be submitted by industry, there is a legal obligation for industry to submit any data, whether positive or not, to the EMA. If they don't do that, they're liable. They're liable for it. So that's very clear. Whatever studies that will have a bearing on the benefits and risk of a medicine have to be submitted by the industry to the EMA. And I think that is it.
Okay, a couple of comments. I'll pick up a couple of the points. The real-world data thing, I'd emphasise this isn't a pharmaceutical industry agenda. It's a huge opportunity. I mean, we all know that a lot of medicines don't work as expected or as we hope in patients, and the extent to which they don't work is really quite large. What's happened is, because of technology, not pharmaceutical technology, but IT technology, we actually started to have the potential to measure what actually works in real life. Now, believe it or not, that didn't happen to the same extent in the past, and it will transform our health systems. Hopefully, it will contribute to their sustainability. It will also transform drug development, but it's a much bigger change than just the pharmaceutical industry. Second thing I wanted to respond to was on privacy. I very much endorse what Noel said. We are very cautious about saying what we think is anonymous data. We're cautious because part of this transparency exercise for us is actually that you retain people's trust in the research process. And part of that trust, and Sheila's working on some of the other parts of it as well, but part of that trust is that people's data is used responsibly and they're protected from inadvertent disclosure. Now we know, and I think there have been recent examples in the UK, where people have asserted that certain data sets are anonymous. They've been put in the public domain or shared with people, and then innovative academics in particular have demonstrated that no, with a bit of data mining and a bit of integrating of different databases, it's possible to re-identify people. That's the modern world. So, you know, we think the caution is entirely appropriate. Clearly, the caution shouldn't prevent us from using this data, but you know, given the way technologies are developing, we cannot afford to be complacent about what constitutes anonymisation.
Thank you. Sheila?
Thanks, Martin. I wanted to just particularly answer the question about whether the shift towards personalised medicine would make this debate about clinical trial transparency redundant. And I would answer strongly that no, it's going to make it even more important. There's vast swathes of data from people, patients mostly, who've been in parts of clinical trials that's not being used for anything, not being looked at, that has the potential to open up new alleyways of innovation, to open up the uses of medicines that may have been terminated before. Now that we have new technologies where we can screen certain subsections of population and perhaps, you know, pull out people who may have had side effects from a medicine in the past, now make the medicine useful again with all the new data and information that's available. So I would strongly say, no, not at all. We need more access to it. You know, the hundreds of requests for data that Brendan mentioned in his talk, the vast majority of those requests have been from independent researchers looking to start new research projects, just like those, not from competitors. We've looked at those requests. They've not come from competitors. We were told many times at the beginning of this that if more information is available, it would be used by competitors to try and catch their competitors out. We've not seen that in practice. The vast majority of projects that are going on are like the project that's been run by the Gates Foundation and the European Development Agency, using data from a number of, I think it's GSK, vaccine trials on children and infants in Latin America. Their aim was in combining data about side effects from vaccines, the causes and impacts of side effects from retrovirus vaccines in Latin America. They wanted to see how they could help reduce side effects of vaccines in future and look at looking after children properly and better when vaccine programs are being rolled out in the developing world. Those are the kind of projects that are being run with more data that's being made available. Those are the kind of things that are being made possible. And I'd like to, if I may make one more point, Martin, to add my voice to Fergal's in saying that the work of the EMA really has genuinely led the way on this. The more we move forward on the work the EMA is doing, and especially on its stance now, that information and clinical study reports, those huge technical documents that companies produce when applying for licensing of medicines, should not be considered commercially confidential. When we look at the EMA's work, when we look at what's happening in the real world, when more data is being made available, the arguments against transparency are just being swept away.
Thank you very much. We're going to close this session now. I'm very sorry for all those who had burning questions, and certainly very important ones, I have no doubt, but we are very behind schedule and we have to move on.